We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MediClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MediClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we are now coming up today with the 2nd edition of MediClasses Basic Pediatric Endocrinology.
So this is the case of a 7-year-old girl who has a severe obesity. BMI was more than 3 standard deviation, had a pre-diabetes, and developmental history and all thing was normal. Genetic testing has been sent by a pediatrician, and that came as negative. And this is the patient. So does it require genetic reports? No. So in this case, it was overdiagnosed as the genetic obesity. So what I'm going to talk about next 10-15 minutes, that when to think about genetic obesity and when not to think. So mainly obesity we can divide into mainly 2 categories. One is the physiological, where growth and development and vision is normal. And second is a pathological, where you will find one gene is defected, which is a monogenic obesity, They do have a entire spectrum of disorder, which is a syndromic obesity, where you find the hyperphagia, vision, and the puberty issue. And another type where you find the hypothalamic damage, and because of that obesity occur, it is a hypothalamic obesity. Third is the endocrine, where you are very well experienced that growth is mainly affected. So when we need to suspect about the genetic obesity, so this is the guideline, endocrine society guideline. We suggest genetic obesity if it is present at very early age, before 5 years of age, there is a severe obesity, and if there is a hyperphagia is there. So 3 points we have to take into the consideration. That is the most common case presentation that we have to think about genetic obesity. Yeah. So as sir is as sir has told, that when we need to think about genetic obesity, is mother is coming to your OPD and mother is complaining that my child is severely obese and age is less than 5 years of age. This kind of presentation you can see. You find depressed child and worrisome parents. Mother is complaining, my child is always hungry, they have to lock the fridge, the child is eating from garbage, the child is eating ice. That kind of complaint if you are seeing. And a mother is especially complaining that I have lost control over my child, because I constantly child is eating and eating from garbage, and a mother is asking for meditation to stop her hyperphagia. In this case, you have to think about genetic obesity. Yeah. So as we, Dr. Nitya has said, when we think about something which is associated with genetics, if it is severe, okay, how much severe? If below 5 years of age, then we have to consider, we have to think about genetic obesity, but the prevalence is always very low. Among the less than 5 years of age, you will find 5% case has a genetic obesity. Uh, if they have hyperphagia, then you have to if they have severity, severe obesity, severe BMI included, then you have to think about, are they taking excessive junk food? That in that case you don't have to think about. If they have, you have to rule out the endocrine causes as well as. Yes, if family is affected, if parents is affected, in this case, you have to think about genetic obesity, and the syndromic features is there. You have to think about genetic obesity. So why obesity occur? So it is always balance between the intake and the energy expenditure. We eat for the survival pleasure. Here, suppose if we have gulab jambu, then we can eat more. So we eat for the pleasure, and we have different centers for working for that. No, there is a interplay between the ghrelin and the leptin. What is the ghrelin? Ghrelin is a hunger hormone, and the leptin is a satiety hormones. So if there is a mismatch between two hormones, then it can cause the obesity. Mainly the genetic obesity can cause due to the leptin defect, and it is mainly due to the satiety issue. That is, this is a very complex slide. So we do have a two hormone from the GI tract and the stomach, which tells to our brain that I'm hungry, I need to eat. So this is the hunger signaling. And second one is that we do have, if we have enough eaten, then we, from our adipose side, there is a leptin secretion which goes to our brain and which tell to our brain that now I'm enough, I have eaten well, so I have to stop eating. So this is the mainly there is a regulation of hunger and satiety center. And this is the simplified approach. From the fat cell, there is a secretion of the leptin, which goes to your brain, which work on the POMC. POMC, they go to the MC4 receptor, and for there, you will have a signal of satiation. And so if I divide genetic obesity, then if one gene is affected, then we can call as a genetic monogenic obesity. If whole entire spectrum of disease is there, then we can call as a syndromic obesity. In the genetic obesity, you find developmentally normal child. In there is a leptin deficiency, could be the leptin resistance, POMC, MC4 receptor defect. If development is affected, then post MC4 receptor defect you can find. In the cases of the syndromic obesity, you are very well aware about the Prader-Willi syndrome, Prader-Willi syndrome, Alstrom syndrome. So I'm going to talk about the monogenic obesity right now. So are you seeing the mouse? This mice. Yeah. So same age mice is there, and this child has a double weight than the two previous mice. So, and then the scientist has found that this has a obesity because there is a absence of leptin called gene in this mice, and this is how the leptin deficiency has been found. So this is the case of the leptin deficiency. You will find mutation in the leptin receptor. Here, if you do the leptin, then leptin level is very, very low. So if leptin is low, then it is a more specific for the leptin deficiency rather than the high leptin. So here you will find low leptin, and prevalence is extremely rare. So by this discovery, scientists were very happy that if we give leptin to everyone, then everyone will be treated. But no. So there was only few rare cases is there which have a leptin deficiency. And by the diagnostic test, you have to do leptin and the genetic treatment. And the treatment is a methyleptin available, which is available in injection form, subcutaneous. So this is the children who are at the 3 year of age, weight was 40 kg, and after the leptin treatment at the 29 kg of weight at the 6 year. And you can appreciate this the weight at the 8 year. The child had a weight of 86 kg. And this is the mouse of the leptin receptor deficiency. So leptin was there, but it was not working. So they do have a similar kind of presentation. They begin with the very normal weight, and as they age progress, they turn into severe obesity. And this is the child at the 2 year of age. You can find the 38.7 kilogram per meter square of weight. So how severe obesity you can see in this defect. So how does it occur? So it is due to the mutation of the leptin receptor defect, and it is very rare, and the phenotype you will find similar to the leptin deficiency. Like you will have a severe obesity with a problem in the pubertal development, because leptin is a toll maker for the puberty and the growth. And the diagnostic test here, you will find, if the leptin you do, then you will find a high leptin, and confirmatory result will be the genetic testing. And what are the treatment available? Now MC4 receptor agonist is working well with this kind of the obesity, which is setmelanotide. Yeah. So this is the POMC mutation. I think you all are aware. This is a 2-year-old boy who has a severe obesity, presented with a neonatal hypoglycemia, and he had a frequent respiratory infection and found to have a adrenal insufficiency with the thyroid deficiency. So generally in the adrenal insufficiency, you found children with a low weight, but here there was a obesity with the adrenal insufficiency. Though this was the defect of the POMC defect. And what is the treatment? Treatment option is a hydrocortisone. You have to replace, and you can try with the MC4 receptor agonist in some case study. So this is the POMC mutation. By giving the MC4 receptor, how dramatically weight reduction is there. Another is a pro-hormone convertase deficiency, where you will have a defect of the insulin metabolism. So you will have a diabetes. You have a diabetes insipidus because of the AVP is not secreting, and you have GnRH deficiency along with the severe obesity. And here treatment is a hormone replacement. And again, MC4 receptor mutation. In this case, treatment is very nicely available, that where MC4 receptor is not working. Here you will find very tall child because of the insulin resistance, and there will be a severe insulin resistance will be there. And how you will diagnose? It is by the genetic testing, and let me tell you that it is very it is very common in the monogenic obesity. So among the 3 to 5% of the case you will find of MC4 receptor. And treatment is very nice. MC4 receptor, which has been launched, which is approved after November 2020 by the FDA. And the setmelanotide has a promising result, not only for the MC4 receptor, but also for the POMC defect, for the PCSK1 defect, leptin receptor deficiency, and also for the Bardet-Biedl syndrome. So I am going to talk about the syndromic obesity. So when you have to suspect about the syndromic obesity, if it is severe obesity, mental retardation, you will find organ related some developmental abnormality. And if you find the family is included. So I think this child is not looking obese, But what I want to convey that this child has a hypotonia and the feeding tube is inside her mouth. So that means he has a feeding difficulty with the hypotonia. So this could be the presentation of the Prader-Willi syndrome during the infancy. And as the age progress, they start developing obesity due to the hyperphagia. And this is the child that we have managed in the Kanpur with the sir. And he was admitted for the respiratory failure, almond-shaped eye, acromicra, micropenis. All symptoms was there of the Prader-Willi syndrome. And why does it occur? It is occur due to the different pathology. It is mainly imprinting defect, where mainly in this majority of case you will find the paternal deletion. In some case you will find maternal duplication and imprinting defect. And what is the treatment option is available? Here you can give the growth hormone after ENT workup. And GLP-1 analogs has been tried, liraglutide, but it decreased the hyperphagia score rather than the decreasing the obesity. And here the behavior therapy and dietary restriction is the mainstay of the treatment. So, and the carbetocin, the oxytocin has been tried for this patient, and it has it gave some result that the carbetocin 3.2 milligram has been a very good response in decreasing the hyperphagia in the Prader-Willi syndrome. So this is the case of the Prader-Willi syndrome, that you will have a difficulty in the vision mainly, and you will find polydactyly. And also cilia is also affected. So there are the features that if you have a primary criteria and the secondary criteria. So if you have four primary criteria, then you can label as a Prader-Willi syndrome. And if you have 3 primary plus 2 secondary, then you can label as a Prader-Willi syndrome. And diet restriction, metformin was a previous available treatment. Now, since 2020, you can give a trial of the setmelanotide here. And this is the case that I have managed, that you can appreciate in the picture that the child has a very short stature, obesity with the brachydactyly, and there was a hypocalcemia at the onset. So this is the case of PHP, pseudo hypoparathyroidism. And it occurred due to the inactivating mutation of the GNS1. And if you find the normal parameter, biochemical parameter, then it can be coming from the father. So it is a pseudo hypoparathyroidism. If mother is if it is coming from the mother, then you will have a AHO phenotype plus the biochemical parameter. So syndromic causes of the obesity, in that case Prader-Willi syndrome is most common. There you have a treatment of the growth hormone, GnRH, GLP analogs you can try if diabetes develop. And in the pseudo hypoparathyroidism, we can give trial of MC4 receptor agonist, but it is not well established. Another Prader-Willi with the metformin, you can give a setmelanotide, and for the Alstrom, and another syndrome, you have to give a lifestyle modification. So if I summarize my slide, then if growth, puberty, and everything is normal, then you can label as an exogenous obesity. You have to work up for the obesity complication rather than the diagnosis. If it is all things is affected, if slow growth is there, then it is endocrine obesity. If the early onset, you find the developmental delay, if you find the dysmorphism, then you have to think about the syndromic obesity. You do karyotype, you do methylation, you do FISH. And if it is you find abnormal, then it is Prader-Willi syndrome. If it is everything is normal and you will find the defect in the vision, then it could be the Prader-Willi syndrome or Cohen syndrome. Everything is normal, development is affected, then it is a BDNF1 type. And another reason, if developmental delay is not there, then you can see for them genetic kind of obesity. If you do leptin, if leptin is low, then you can label as the leptin deficiency. If it is normal, then you can label as a post-leptin receptor deficiency, like MC4 leptin receptor deficiency or the POMC deficiency.